Hi, my name is Dr. Ron Lehman. I'm an orthopedic spine surgeon at Columbia in New York City. And tonight we're going to be talking about robotics in spine surgery and really the early adopters and how it's changed our practice and really how it continues to change and evolve the field of spine surgery. Joining me will be Dr. Jeffrey Gum, who's a orthopedic spine surgeon in Louisville, Kentucky, as well as Avery Buchholz, who's a neurosurgeon at University of Virginia in Charlottesville, Virginia. And we'll all share our experiences, and then we'll come together and sort of talk about some of the pros and cons, pearls and pitfalls, and different things surrounding this technology. So I'll get us started with talking a little bit about how this changed my surgical practice. Many different things I think have really occurred. In the first 12 years of my practice, I really did all freehand technique screws. So certainly training at WashU in St. Louis, I think one of the benefits of that is you get to learn how to do things quite well. But then the other component too is that the navigation and robotic assistance really helps you to plan as well as you customize your implants. But when we do surgeries, one of the things that's the biggest concern is that we have a lot of things that we're really thinking about. Do we do it open or closed, minimally invasive? What type of decompression do we do? We're thinking about inner body. Many different things along this surgical pathway occur. And what we're really trying to do is mitigate this and make things much more objective and streamline much more easily. But what is this all worth when we talk about using assist technology? We've certainly seen cases like this that have come into our office where there could be potentially catastrophic issues, either with screws into the spinal canal or screws into the visceral organs. And once again, these can cause significant issues. But ultimately, we can take a case like this, which is a relatively straightforward adult idiopathic curve, with about a 65, 70 degree thoracolumbar curve with some thoracic kyphosis, and we can sort of think about it. Because right now, many times we do these surgeries and we see these cases and we go to the OR and we do the surgery. But certainly, like Mike Tyson has said in the past, that everyone has really a plan, but once we get into surgery, sometimes things don't go awry. And so the more we can do ahead of time, the less we have to worry about things not going according to what we scheme. We can take this image now and import it into software packages that are very powerful, like X-Align, gives us a better appreciation of what we're doing. And then we can map out our screws, look at what our rods are going to look like, but also get our coronal and sagittal parameters to make sure that we understand what the patient needs before we begin the surgery. And ultimately, do we achieve these goals as we restore this patient back to function? We can also perform osteotomies and correction maneuvers to get the spine more aligned in hopes that we are able to achieve these goals. As you can see on the right-hand side, these software packages like X-Align really allow us to see, do we have lumbar lordosis and sacral slope restored? And we can see that highlighted in green. And so we know what we're gonna do before we get in there, and really helps to shape what we're gonna do in terms of our ultimate goal. But we can also look at things like rod contour, and are we gonna be able to achieve the lordosis and the correction that we want? And what's our rod going to look like? And we can help superimpose this over top of the case. And because it's really nice to be able to see when you take a relatively straightforward curve, you plan it out with schematics, and then you can take your intraoperative scoliosis film and say, well, we achieved exactly what we set out to do. Once again, making this much more objective than the way many of us have done it in the past. In addition, our entire team gets a plan of what our screws are going to be in terms of size, length, and this gets sent to not only our sales rep, but also to the OR nurse, to our fellows and residents, so that everyone's really on the same sheet of music. Because oftentimes we do really large cases, we can have many pans and many trays open in the back table, but this becomes incredibly cumbersome. And not just in terms of that, it's also incredibly expensive. So we certainly know in New York City, it's about $300 per pan or tray to help sterilize and process this. And this is in addition to the shipping costs to and from the manufacturer. So we can really save a lot of this money by having all this stuff mapped out and ready to go. But it also changes our workflow. And I think we've talked about this many times in the past, whether you use freehand navigation or robotic assistance, it changes what you do a little bit, and you really have to find what works best for you. And I think at this point, we have some of these pathways worked out relatively well. And so ultimately, this case, which we planned, we can help this patient get balanced in both the coronal and sagittal plane and ultimately end up with a good result, very much according to how we planned it before we even started the case. But I'm going to really get into the case that changed how I do surgery and really made me consider and understand that robotic assistance is hugely beneficial. And it's a really small case. It's a relatively straightforward one, but I often equate this to the fact if I were a pilot. And when I present these two scenarios, I think this will play out in how you look at and determine if navigation or robotic assistance, or the combination of the two, which we have now with the Mazor Stealth Edition, makes a difference. And so if you're a pilot and you're flying at night, if this is the runway as you come down, you're only relying on your instruments. And I think everyone would probably agree that when we go to land a plane at night, we would much sooner have the runway lit up with knowing exactly how long the runway is and what our lateral boundaries are. And it's really no different than when we use something to do even a small case like a one-level fusion. And here's a case. So this is a minimally invasive TLIF at L4-5. And you can see here, once we have the patient on the table, we use the implants. We now have the pedicles very much outlined by having these this intraoperative fluoro shot of the pedicle markers. We can then do our TLIF. We can distract off the contralateral screws, put our cage in, and this is a 20-degree lordotic titanium implant. And then ultimately, place our screws bilaterally and compress and ensure that we have the lordosis that we set out to achieve. And so I think in this case, with using other things like the lordosis measurement guide, where we can take a fluoro shot to see if we actually achieve the lordosis that we want to achieve, it really helps us make these things much more objective. And I don't think it really matters if it's a small case like this, which is one of the cases that really changed how I approach this, or if it's a case that has a two-level issue as well. And so once again, you can see the post-operative films with this large cage, good lordosis at that segment, but also cases like this, which is just a two-level, very similar, where we really understand we have to achieve this amount of correction. And so because we plan this ahead of time, we know the implants and the precise implants that we're going to use, which we can now look at in the X-Align software, we can understand that from L4 to S1, we're able to go from about 4 degrees lordosis up to 36 degrees. So once again, decreasing the risk of adjacent segment degeneration, but all with very precise planning and by knowing the implants that we're going to use by doing this case. And then we can take this further, even with smaller cases. Once again, a Division I collegiate gymnast with a pars fracture, we can take a look at the AP and lateral radiographs. And with the robotic assistance, we can easily put the pedicle screw into the pedicle to start the case. We have our skin incision planned out, and then we can use the quadrant system to go down, follow that pedicle screw, be able to find our pars defect, place our hook, and then ultimately end up with a construct through a very small incision. But once again, this makes it very reproducible and very much comparatively. So we can see what the construct ends up with in terms of this bilateral pars repair. But once again, a very straightforward case, and we're not really worried about placing the implants because this not only helps place our implants, but also helps us find the pars fracture as well as plants our skin incision. And then we're also able to use things in terms of simultaneous surgery where we do an anti-psoas approach. Here's a grade 2 spondylolisthesis at L4-5. You can see the sclerotic bone and significant lateral osteophyte formation from this long-standing problem, with our MRI showing spinal stenosis with subsequent radiculopathy with really one-level disease. And as we do this and get the preoperative CT scan for the pre-op CT to fluoro workflow, we can also see that this bone is very sclerotic, which allows us to know that we can really do an aggressive discectomy, and these end plates are going to be able to hold our cage and be able to help with this. And then at the same time, we can take this and with simultaneous surgery, be able to get this implant in position. And once again, by looking at this, we were able to get this in the right spot without having to reposition the patient, which really saves us a lot of time. So the only case that they do that helps me save surgical time by not having to reposition and not having to re-prep and re-drape. So I think at this point, it's suffice to say that robotic assistants are here to stay. Many other industries, including aviation, the military, and manufacturing, and for the automobile industry, are all using these technologies. And so at this point, it's really implores us to be able to use this technology and to help continue to develop this and improve our workflows. We also have to maintain and be cognizant of the fact that with this technology, we have to continue to still teach some of the tried and true methods in case there is an issue in order to make sure that the next generation of surgeons has all these things at its armamentarium. Thank you.
Okay. Thanks, Ron. That was a great presentation, great introduction, and I'm happy to be here as well. And again, my name is Avery Buchholz. I'm from the University of Virginia, and I'll be continuing this discussion. So, not unlike yourself, I had a similar experience in training. I trained with Doctors Chris Shaffrey and Justin Smith, both of whom are largely adult deformity surgeons, and really the majority of their practice is open practice. So lots of fluoroscopy, some freehand screws, and that's really the way I was trained in fellowship. Currently, I'm back at University of Virginia, and my practice is very similar to that as well, where it's a lot of adult deformity. But I do have some background in minimally invasive surgery, and I do try and do minimally invasive surgery whenever I can. But for me, deformity is still an open surgery, and I find it more reproducible, and that's how I prefer to do it. So I did use some robotic assistance doing some minimally invasive cases for percutaneous pedicle screws, and I found it a very simplified way to do the surgery. It was helpful. It reduced stress. The software was great. And I was trying to find a way to bring that into the rest of my practice with adult deformity cases. And so that's really where I'm doing the most of my robotic assistance now, is with those cases. And I found it a good way to reduce intraoperative fluoroscopy. I found that it helps with screw placement, some of these difficult pedicle screws. I've also found it reduces a lot of stress in the OR, and we'll go through some of this today. So I haven't been doing robotic assisted surgery as long as you have, and same with Dr. Gum. I think you both can do it longer. We got our robot back in February of 2019, and it was Mazor X initially, and we upgraded to Stealth Edition after that. So we'll talk about both cases. And one of the reasons we're all interested in robotic technology is that it's really here to stay. We've seen it be helpful. People are engaged by it, and we all know it's beneficial. So I think it's good that we're all talking about it. This is one of the first adult deformity cases we did, and this was back with the Mazor X system. So this is a 72-year-old female, idiopathic scoliosis, very stiff curve, lots of osteophytes, has had some prior surgeries, but got to the point of progressive back pain and leg pain where we needed to do something additional. And these are some of the pedicles we're talking about. And I know in your training, Ron and Jeff, you guys did a lot of freehand pedicle screws with Dr. Lenke. And this is something you're all very comfortable with. We did a lot of that to my training as well, but these are still difficult pedicles to hit. And no matter how well you train, some assistance is always beneficial. And I think going through a case like this, where you can plan out and look at your screw trajectories beforehand, gives you a little bit of extra confidence when you're going into the case. So this is that same patient we looked at with the same pedicles we just saw. And these are our screws that we have planned out. So these are in, out, in. And again, I think going through this gives you some extra confidence in the case. We can go through and be a little bit more at ease during the surgery. I did not do a lot of navigation before robotic assistance, but even with navigation, I think there's still some fiddle factor for me in the OR. Whereas with robotic technology, you're doing a lot of your thinking preoperatively and then executing during the case. And again, here's us going through and mapping out some of these pedicle screws. Again, this is at L2. And you get to go through and look at your plan, just like you showed, Ron. It does give you some confidence to go through and look at where your screws are, where your trajectories are, and what to expect during the case. The software also has the ability to look at angles of rotation. You can see 14 degrees of rotation between L1 and L2. You can look at Cobb angles, coronal angles. You can look at a CT scan that was done preoperatively. And this is our end result with this particular case. So again, we were happy with the screw placement. We did take pictures, and our planned screws matched up with our screws that we achieved during the case, and we were happy with the results of that case. So then we upgraded to the Stealth Edition. And I think what that did for us is brings the benefit of the Mazor technology with Medtronic's Stealth system, which is one of the most successful and reliable navigation platforms on the market. It's on thousands and thousands of cases, and bringing those two things together, I think, really adds a new level of expertise. So this is our second case we did with the Stealth Edition. This is a 71-year-old female with progressive coronal imbalance, in pain, disability, and progressive to the point of needing a more definitive surgery. And again, we have the chance to go through. We plan our screws out. I think one of the things the robotic assistance has changed for my practice is more S2AI screws. I was a traditional iliac screw freehand placer, and now I'm doing a lot more S2AI screws, and they do line up very nice in these constructs, and the results have been good. And again, we go through and we plan out our screws. The software is great. We look at our angles. We can measure all this on the software as it is now, looking at our pelvic angles, our cob angles, etc. We can measure out and plan out our S2AI screws and make sure everything maps up and matches accordingly. And again, this is a video of us doing this deformity case here. So I think we're using a bridge mount that's mounted at the L1-2 levels. For this particular case, and usually a T10 to pelvis, we'll do 2 registrations. So here we are doing the 3 define. We map out the working arm in time and space there. We look at the top and the bottom of our construct. I do a lot of CT to flora, and so most of the cases we do are CT to flora, and here's our couple flora shots that we come in and take and register. And so here we are working with our residents and fellows. We're gonna do, we're gonna dock, we're going to drill, and all this is gonna give us real-time feedback with the navigation. So you can see us drilling outer level here, and you're getting stealth feedback. And this is some of the benefit, and it adds an extra level of confidence during the case, is getting that real-time feedback. Here we are tapping, and I'm not afraid to go in and still stick a ball tip feeler down a pedicle in these open cases if I just want to check and verify where we are. And you'll see us doing that here after we tap this level. And that's something with some of these more difficult pedicle screws that I still do just to make myself feel that much more secure. And here we are feeling that pedicle. And again, we've got residents and fellows, and we're all working together in these cases. In an open case like this, it's a lot easier to see where the depth you want to stop at with that screw is. But again, you'll see on the screen some of that feedback you get in terms of where your pedicle screw is. And you can see the superimposed pedicle screw you planned. You can see us advancing our real-time pedicle screw there, and we'll know when to stop and where to stop, and we'll know that it's accurate based on the feedback we're getting from the stealth navigation. So these are some things that we do. And these are some of the things that have made these cases a little less stressful for us. And again, S2AI screws is another way that we've done these cases, and it does help. And I found these to be more beneficial screws to place now in these long constructs. And again, here's some of that feedback when we're mapping this out. And again, now we'll be tapping, and then we'll place our S2AI screw. Here we are tapping. And it does get the whole room engaged. When you have this kind of feedback, we can have the screws ready to go. Everyone can see what's going on the screen. Everyone's ready for the next steps. And it has made the entire team just a little bit more engaged, and it is quite a good workflow for us. And again, here's the end result of that case. So again, we took x-rays. We were happy with the way the screws lined up. We were happy with what we had planned compared to what we achieved. An overall good result for that patient. And here's another case. I think this really highlights one of the true benefits for me of this robotic assistance technology. But this is a 33-year-old female with idiopathic scoliosis. And she's had, probably 15 surgeries prior to this. She's had infection. She's had hardware removed. She's previously been fused T4 all the way to the S1, and she's got really a bony fusion mass all the way down there. But she, again, has had progressive pain, progressive disability, and needs a more definitive surgery. So here we are looking at a preoperative CT scan from this patient. You see the small pedicle she has. Again, we talked about some of the challenges hitting these pedicles. And with her in particular, you see the bony fusion mass she has, where intraoperatively, there's gonna be relatively little bony anatomy to identify your starting point. This is gonna be challenging screws. Again, people do these freehand. They do a fluoroscopic assist, but they are challenging. You can see where we have planned our screws in this particular case. And normally what I'd be doing for a freehand or fluoroscopic assistance case would be airplaning the bed, we'd be rotating the bed, we'd be trying to match up these pedicles. And I think using the robotic assisted technology, you avoid some of that. So again, here's us doing one of these in-out-in screws. You can see the bony fusion mass. And again, the robotic arm has told us where to make our starting point. It's going to assist us in placing the trajectory we want. And here we are drilling across that pedicle in, out, in. And again, getting the real-time feedback with the stealth system. Here we are again tapping that same trajectory. We'll still feel it with a ball tip feeler to make sure we're happy with it. And then we'll place our pedicle screw. But again, these are the kind of cases that they do add stress to your case. And this sort of technology does bring benefit in that ability to assist you and help you place the pedicle in the correct location and with one pass. And so here's us placing that screw. And again, getting that real-time feedback. And so that's really one of the things that I've found most helpful with this sort of technology, is that ability to place these more difficult pedicle screws. And again, here's an intraoperative CT scan showing the pedicles where they ultimately were placed. And again, you can match those to where we had intended our pedicles to be, and we were very happy with that result. And here's her postoperatively, and again, I think we were able to achieve nice correction on here in large part due to the ability to place good pedicle screws for this patient. And this is the last case we'll present. This is a 44-year-old female with idiopathic scoliosis and worsening L5 radiculopathy. She really does not have significant back pain, but it's more L5 radiculopathy. In this particular case, we're trying to avoid a deformity correction. Here's an MRI showing that L5S1 foraminal stenosis and the radiculopathy. And so we decided to do this case as a minimally invasive case with an anterior-based surgery. Here's us planning out our pedicle screws. You can see the tower superimposed. You can see that technology allows you to plan where your incisions are going to be, what your incisions are going to look like, where your towers are going to be sticking out of the patient. In this particular CT scan, we're looking at the PSIS, so we're going to place a posterior superior iliac pin, and we're going to do this in the lateral position. So that's why we're looking at the CT scan here. So we placed our Shands pin, we registered the robots, and here we are going through, and we'll look at a little bit of this here. Again, we're doing this in the lateral position, so this is a single position surgery. While we're doing our pedicle screws, we've got our access team, our vascular surgery access team in the front of the patient, and they'll be getting access as we're placing our screws posteriorly. And this is going to be a pretty quick process for us. By the time we get our screws placed, they'll be pretty close to when they're ready to have us come and do our anterior portion of the case. But again, this is with the Stealth Edition, and you'll see some of the benefits of this here. So again, we make our incision, we dock, we check, we verify accuracy, which we see here. When we do these cases, we'll oftentimes use an anti-skive pin, which you can see after we place our docking teeth. We'll place a skive pin before there we are, before we place our teeth. And that's something that we found helpful to penetrate the bone and to gain a little more access and have a little more security in these cases. Here we are placing a teeth over the anti-skive pin. And again, all this is finesse. So we've done more and more surgeries in the lateral position with single position surgeries, and we've been very happy with the results of it. But you do have to use finesse with those particular cases, and it is something Medtronic's working more and more towards a teaching method and educating surgeons on that. But here's some of the real-time feedback we get using the Stealth portion of the navigation. Again, you can see us placing our screw, getting that feedback. And again, in these minimally invasive cases, we know where our screw is at the proper depth and where to stop advancing it when we have that superimposed screw and the Stealth portion of the feedback. And again, here's placing a second screw there. And again, we use the Mazor system as a tool. I think as a surgeon, you still have to be aware of what you're doing, be able to recognize anything if it feels wrong or if you sense it's wrong. There is potential for things to be wrong, but you have to be an active participant with the technology, but it does simplify your life in terms of ease of use and reduce stress and efficiency in the OR. But again, it is a tool to be used as an assisted device, and you can't rely solely on it. You do have to be careful and make sure you're using it appropriately. But for us, it has been helpful. And again, there's an example of placing those percutaneous screws in a single position. And here's our result. Again, happy with where we had planned things preoperatively, happy with our results postoperatively. And so for me, the Mazor and the robotic technology has really been ease of use. So there's lots of stressful things in the OR, and this has reduced a lot of them. So during the case, lots of reduced stress. Spine surgery is labor intensive, it's stressful, and if we can have technology like this that reduces that burden of stress and the workload, I think it's beneficial, and I've enjoyed using it and bringing it into the OR. Preoperative planning does add confidence, so going into a case, there is that added bonus of you've been through this, you know what to expect, and you've gained that confidence of planning the case out. I've had a significant reduction in radiation. We use very few fluoro shots during the case at any these days. And I think that's beneficial for the surgeon and the team in the OR. We've had very good success of accuracy of screws with these patients. I think most people I've talked to using the Mazor system have echoed that. It has reduced OR time for us, in all honesty. Early on, there may have been a few minutes added for registration, but we've really got pretty facile on this, and it's been a benefit in terms of OR time reduction. And I think there's a huge upside and potential in the future for these things. We all talk about, are we going to be able to use this technology for osteotomies, for drilling lamina, for cage placement? I think these are all potential things that we're working on and will work too. And as an early adopter, I'm eager to help advance that. So using the Mazor Stealth Edition has brought in some other benefits for us. There's the feedback, the surgeon experience, the patient experience, that we have a whole team involved in the OR now. And I think it opens the door for future applications. We're already seeing lots of ability to navigate other parts of the case. And I think bringing this all into the same platform is close to being real time in the future.
All right, so I'm Jeffrey Gum from Norton Otherman Spine Center in Louisville, Kentucky. Ron and Avery, those were fantastic talks and reasons why we utilize robotic-assisted surgery in the realm of spine. Here's disclosures that I have. So the 50th SRS meeting in Minneapolis in 2015, there was a panel. It was Larry Linke, Dave Pauly, Steve Glassman, and I think there's another surgeon that was invited to get up there and give a talk about where the last 50 years in spine surgery were and where they think the next 50 years are going. And the consensus of the panel was everybody was very excited to put that talk together. And when they started to put it together and got up on stage, they realized that over the past 50 years, there's been advances in instrumentation, there's been advances in elegant biologics or powerful biologics, but overall the OR looked pretty similar, and there wasn't these kind of big breakthroughs that they envisioned when they started their career. And so across the board, they all agreed that they felt the next 50 years was going to be a bigger or more drastic change with what the appearance of our OR looked like. And I think robotics is going to be a big change or a big facelift to what they were talking about. So currently, robotic guidance in medicine, there's over 30 applications beyond spine, including orthopedics. There's a lot of soft tissue applications. If you look at the number of patent applications with regards to robotic guidance, that's growing almost exponentially to this point. Examples of success in robotic guidance, Da Vinci is kind of the gold standard, right? So in '99, Da Vinci was launched, and up to 2018, there's been over 5 million MIS surgeries completed with Da Vinci, over 4,400 systems placed. And what's interesting about the Da Vinci system, they've actually taken procedures and turned it into the gold standard, right? So robotic assisted, prostatectomy, hysterectomy, things like that are now considered gold standard to utilize technology like that. The question is why would this be beneficial in spinal robotic guidance, right? Beyond what Avery just pointed out with stress reduction and construct planning and other things that Ron pointed out to, just allow us to think different aspects of the case. If you put your C-suite or your economics hat on, there's a pretty convincing argument that there's a good reason to introduce robotics in the spine. Me and Avery shared this slide and have so for other talks in the past, but the part that I like to highlight, even though this is a little bit outdated, that they predict that there's a critical demand, right? So once we get to robotic guidance being used in about 35% of cases or penetration within the country, all of a sudden surgeons are going to start to demand this type of technology, and we're not there yet, but we're getting very close. And so to paint the picture of why I think robotics is so beneficial, it starts really with my story and my practice overview. So similar to Ron and Avery, I grew up when training doing a lot of freehand, a lot of deformity. My residency was at Leatherman, where I ended up staying on. I did fellowship at WashU, where Ron was there for a small amount of time. And it was right before the mass exodus. So a lot of freehand, very little MIS. My current practice volume is about 60% degen, about 40% deformity. And my approach when I started was maximally invasive, right? Not minimally invasive. There was really no discussion of tubular things, no adjunct technology. It was all very, very wide open and freehand technique. And so I knew I was interested in the thought of robotics or robotic guidance and the application in spine. And so to me, one of the biggest benefits is to make that transition from this very wide open training to other types of thought processes or techniques in spine. And so I went to my hospital and told them that I was interested in the robot, and I kicked and screamed and cried for about 18 months trying to get it. Then we got pretty creative and came up with the idea of doing a 20-case trial. And that allowed me to understand the return on investment for the hospital. Why were they a little hesitant to introducing it to our system? And there's some political issues behind that. But overall, I started to pay attention to the economics of the case, right? So what kind of cases am I going to choose for this 20-case trial? And, deformity is what I'm passionate about and interested in. And I was like, okay, this is going to be great. I can reduce case cost and less stress per screw, get them out of the hospital a little quicker. But when I started to think about it, if I had a couple of complications, which is inherent to deformity surgery, and they stayed in the hospital long or needed a reoperation, my hospital would be very quick to throw stones at the robot and say it's the robot or robotic system's fault. And I knew that wouldn't be the case. So I wanted to pick cases that I thought would be economically beneficial from a hospital perspective. So in that time frame, we were transitioning to really paying attention to length of stay. I was starting to introduce different types of procedures into my practice. And I felt like this was a really good platform to introduce MIS type techniques into my practice. So I started to introduce cortical screws and the midlift procedure. And really quickly, I figured out that these types of procedures are perfect starting points for introducing robotic guidance into your practice. So first of all, cortical screws are a inside out type trajectory. You typically use fluoroscopy or navigation, some sort of assist to help with that. You're not freehanding that because it's all cortical pathway. You don't get the tactile feedback as you do in a cancellous channel of a pedicle. So when I introduced the robotic system, I quickly realized that it became substitutive. So out of the gate, I didn't just add another layer of technology or time to my OR flow. So it took either fluoroscopy or OR out of my workflow, and then I added the robotic system on top of that. So it became substitutive. So that's one of the reasons why robotic-assisted cortical screws I became a very big fan of, and I think it's a good entry point into practice. Number two, it allows you to trust the system, right? So this gradual trust where, percutaneous MIS techniques are very valuable and very easy to utilize with this platform. But, to make an incision, trust the robotic arm and the navigation guidance without learning how the system works is a big leap of faith, in my opinion. So I use the example of a electric car that people are very familiar with that has automated driving or automated pilot. When you go and purchase that car, very few people, if anybody, puts the autopilot on and drives off the lot, right? So you learn to trust the car, you learn to trust the technology before you take that big leap of faith. And so when I was doing robotic assisted cortical screws, I get to watch the cannula interface with the bone, right? And so I get to see that it's landing on the anatomy that I'm planning it on. So I got to get comfortable with the system, right? So I understood the failure points of the technology. I got to watch for shift or skive or reasons for failure. And so that's the second reason why I think it's a really good intro into robotics into your practice. And the third portion is really this construct planning. So not just how do I plan my screws and what's it look like? What's the entire construct look like, right? In understanding that and spending the time up front is very valuable. You learn a lot more about your case. You get to optimize your incision, and you get to optimize your planning. So one thing with cortical screws is you have a lot of real estate in the sagittal plane to still land in the same portion of bone, and you can manipulate that. So I like to manipulate the trajectories of my screws to fall pretty close on the skin where the line of sight for my interbody work is. And so that truly allowed me to minimize my incision with proper planning. On the left, the image on the left shows, my cortical screw construct prior to introducing robotic assistance into my practice. And those screws were pretty aggressive up and out at the UIB and the LIB. And then what I figured out is there's no reason for the LIB screws to have a trajectory like that because my incision is bigger. So I can converge that LIB screw and actually go through the facet on that distal screw and make that construct converge on the skin and truly minimize my incision. Here's an image of actually one of the first cases, actually the first case that we did with the Mazor Stealth Edition. And it's a 3-level, sorry, 8 screws, 3-level construct where you could see the construct in the coronal plane. The rod fits in perfect. There's no deviation in the coronal plane. If you look in the sagittal plane, we converged all the trajectories onto the skin to make a very small incision for this. And the center image shows an axial view where that screw actually goes through the facet. We're fusing that facet. That facet gets prepped prior to that screw going through the facet. So it really doesn't matter. You don't have to stay out of that when you're doing your distal screws or mid-construct screws. So number 3 reason why I think this is a good introduction of robotic guidance into your practice is it truly allows you to minimize your incision and plane your construct very well. So here's the standing x-rays after that surgery. You can see, so there's spondylolisthesis, degenerative disc disease. We did anterior work at L5S1 and then a T-lift at L4, L5. But overall, construct flows very well. And we did this through about 7.5 centimeter incision. Another case example, so you can see very flat from L4 to S1, 2-level construct with some anterior work, and then combined with a T-lift, we restored our lordosis well. Construct was done through a 4-centimeter incision. Here's another example of a grade 2 mobile spondy that we did, again, cortical screws with a T-lift. This was done through about a 3-centimeter incision. And so for me, to be able to use these MIS techniques that I did not get trained on, I was not familiar with doing things through a tube or percutaneous, this cortical screw construct in combination with the robotic guidance system allows us to really minimize soft tissue dissection, improves recovery kinetics, and get the patient up moving very quickly. And so that's the reason why this has become my go-to for 1 to 3 level degenerative type procedures. So the cortical screw trajectory in the hands of the robotic system is very beneficial because you need to pay attention when you're planning your construct. If you do these big outside in trajectories with the robotic arm, that's a fixed arm, right? So you actually may end up making your incision or your dissection a little bit bigger with those types of constructs. You also get to visualize your cannula dock on the bone. You get to minimize that sky because you're watching it interact with the bone. You truly minimize that incision. And there's a potential to show economic impact and reduce variability with these types of constructs. Here's a video that has 4 different fields of view. It may be a little choppy because of the recording process, but if you see the upper left, that's a view from the top. I'm lightly tapping that cannula onto the bone, right? And then we initially place our drill in. This has navigation. The upper right corner, you can see that the pre-op plan is teal. And throughout the video, you can see that as we stick our drill in, our tap in, our screw, that overlays that pre-op plan. So you get to confirm that based on the way you plan it versus real time, what that looks like. The bottom left is a little bit different view, and you can see there that this is a 2-level construct that we're doing through a, excuse me, pretty small incision that we have right there. So here's the screw going in. So we're going to see this picked up on the navigation screen in the upper right that overlays perfectly with our preoperative plan of the teal. So we get to get some depth feedback of whether that's going in deep enough. We get to make sure that it's following the same pathway that we had planned preoperatively. So currently we're over 200 robotic assisted surgery with Mazor X or Mazor X Stealth Edition. The majority in my hand have been cortical bone trajectory or mid-lift type constructs. And again, very good way to introduce this technology into your practice because it's substitutive. You get to visualize the cannula, so you get to trust the system. It optimizes your incision. And so we published our initial cohort and we compared this robotic assisted mid-lift for cortical screws to navigated cortical screws and then open T-lift. And if you look at the metrics that we looked at, EBL, OR time, length of stay, and cost, those metrics all going from open to navigated to robotic assist. EBL went down, OR time went down, length of stay went down, cost was about equivalent to the open T-lift, and that's comes a little bit from disposable costs and accessory things that you have to open with the robotic assisted cases. So for me, why robotics? You know, why am I interested in this? Why am I talking about it now? So one, I think all three of us highlighted, that it's a platform to introduce MIS techniques, right? So we were all trained on big whack, open type surgery, and we're now able to incorporate these MIS techniques into our practice. Number two, I think it's a great platform for data capture and analytics, right? So now you're being forced to upload images, CT, and or radiographs preoperatively, and then you capture images throughout the procedure. And so it's a great platform for potential analytics or data capture in the future. Number three, which Avery and Ron both pointed out, it forces you to pre-op plan. It forces you to think through your plan for the case. And this really optimizes your efficiency in the OR, and that's where it matters, right? So don't plan on the fly. It forced me to start planning preoperatively. There's also a potential for massive waste reduction. Ron showed a great image of how much it costs to open a pan, right? So if you can preoperative plan, especially large constructs, right? If you look at the number of pans opened up for a deforming case, we can really reduce that waste because we planned before we entered to the OR. Now we can walk in and potentially have stuff sterile packed or all reduced into one pan. And then really what gets me excited is the future of robotic assisted applications. And so bone cutting type projects are starting now. You know, when platforms like this allow you to help remove bone from a decompression perspective, then it starts to get really exciting. And then lastly, automation, right? So when we have the potential to improve on safety in with automation process regards with planning or potentially even screw insertion, things like that, that's when we start to get real excited about robotic assisted spine surgery. So thank you guys for your time. And I think we have a few more questions and discussions we're going to go through.
Great. Thanks, Jeff and Avery. Two great talks. And I think it brings up a lot of questions. Maybe we can get into the weeds on a few of these because I think, you know, for each of us, it's really changed our practice. And, you know, maybe one sort of continuity is that we all sort of trained on doing very large cases. And even for my practice, when I did fellowship, you know, 15 years ago, I never did a discectomy. I never did a small surgery. I did more 3-column osteotomies during my fellowship than I did discectomies. And so I had to learn going back into a military hospital with a lot of young, healthy people who really, you know, demanded MIS type procedures and these smaller things. And I didn't have, you know, these type of assist technologies. And certainly even looking back on it, if I would have started with, you know, robotic assistance 15 years ago, I think it would have completely changed how I did surgery. But you know, oftentimes, you know, surgeons that are looking at this technology or sort of thinking about it, you know, there's a couple different things that maybe makes this system a little bit different, you know, than others and other technologies. And so maybe I'll get Jeff, you to comment on this first. You know, what are your thoughts about, you know, the attachment and how rigid this system is, you know, with sort of going onto the bed and going onto the patient? Because, you know, as navigation users are always concerned about, if you bump the fiducial, if your patient alignment changes, you then have to sort of rescan. And so what are your thoughts about how this particular system attaches onto the bed and the patient?
Yeah, so I think robust connection to the patient is critical when you're using technology like this. So, you know, the two big failure points, so, you know, whenever I talk about robotic assisted surgery, I always promote and preach understanding failure points of the system, right? You're only as good as the technology you're using. And if you don't understand where it's going to fail you, you're going to end up hurting a patient. And so one of the huge benefits of this setup is that you get a very robust connection to the bed and then to the patient, right? So failure points for the system are shift and skive, right? And so shift, if you have a floor mounted device or you're freely floating above the patient, you have not a robust connection to the patient, you're going to increase your chance by shift exponentially. So the system mounts rigidly to the bed. There are numerous options of ways to mount it to the patient, right? So I'm a big fan of a pin in the pelvis with what's called a bone mount bridge. And if I'm worried about long constructs or their arm reaching real far, I'll put multiple pins. You can even put options onto the spinous processes. So there's a kit that comes with the system that has numerous options for attachment to the patient. But overall, I think the robust connection to the patient, the robust connection to the bed really reduce the chances of shift, which is a big failure point for these types of systems.
Yeah, I think those are great points. And, you know, I guess maybe I'll sort of kick it over to you too, Avery, is, what are your preferred methods when you look at, mounting the system for different types of constructs, minimally invasive versus maybe a longer open deformity? What have you found have been more beneficial in terms of patient mounts or bone mounts?
I like the Shands pin, and I do PSI pins a lot for both open and pert cases. And so that's probably my go-to. For some of the deformity cases, we do use a bone mount bridge, and I had that in one of my videos. We'll oftentimes use bilateral PSIS Shands pins for an open deformity, and that works out great too. The other thing you had mentioned, Ron, is some of the software with the Mazor system and registration. And I would say that is one of the benefits of the system is the software with the Mazor platform is so strong. It registers segmentally level by level. A lot of the systems I've looked at and some that I've used, are not, they don't register that way where you look segmentally level by level. And I think that really reduces your intraoperative error rate. I think it makes registration a lot stronger, and I think gives you a lot more success in the OR. And I've found that to be true in my cases.
Yeah, I think that's one of the things that's really interesting. Certainly, even as you look at the Stealth Edition compared to the previous iterations, or other systems, even whether they be navigation-based systems, is that if you're using Solera implants or Voyager 5.5 system, you actually see what the exact screw looks like, and you see if you're using an article T-lift cage or using other type of implants, you know exactly what the cage is going to look like, even in a 3D rendering. And so I think, like most things, when you put a schematic of a implant in or a cage in there, it's much different than seeing what the actual implant is going to look like, with the lordosis built into it and whatnot. What are your thoughts about, when we do trauma cases, especially oftentimes we'll do, various fractures that don't have a neurologic deficit, and we want to be able to place screws with a percutaneous method, and maybe then place and pass subfascial rods. And so, we do that with Jamshidi needles or even with navigation techniques. I've often found that even when you're pretty facile at it, you'll still have a case every couple that you really have a difficult time placing a 4, 5, 6, 7 level subfascial rod. But what do you think of the benefits of robotic assistance with placing screws and then ultimately placing these rods? Just the fact that really sort of highlighting the fact that you can really sort of perfectly line up your screw heads. Maybe talk us through that a little bit in terms of some of the benefits you see there with this system.
Yeah, and I think you mentioned the big one for me is being able to line up your heads. So when you line your screws up on the software, you can see the depth of the screw, you can see the alignment of the screw, and you can make sure things line up. You can superimpose a rod and drop a rod in on the software and kind of see how that looks. Now that may change a little bit in the case depending on what you do to the bony anatomy, if you correct anything, and that may change. But that's the real benefit for me, is being able to line things up appropriately. Before when I was doing these with Jamshidis and things could be a little bit off, depths may be a little bit off, and it's really hard to get that perfect alignment with the screws.
Yeah, I think it's also a huge benefit of the Stealth Edition, as well as being able to place your screws and knowing how deep they're going so that your screw heads line up. Because all these things that we do, especially with a minimally invasive approach, it really comes down to, and we've all done them, and we all know that sometimes that these approaches are a little bit sort of futzy when it comes to, smaller incisions and everything sort of perfectly lines up, and maybe we're not doing enough of a decortication, or we're sort of skimping on our inner body. But I think when you make it more objective and comparatively, I think it really adds a lot. And I think we talk about this quite a bit, but Jeff showed this in his talk pretty eloquently, is that when we can plan our skin incision also with the system, that makes a big difference, right? So now we can look at, extended tab screws with towers. We also know that we can go from a long plan to a short plan. And now that these screw-based systems like the Voyager, which has an extended tab, because this robot's so precise, you can take the end effector and take it from a trajectory that's higher, and it will go perfectly down concentrically around the screw head. And then when it comes back out, it also understands with the 3 defined that you can then take a nice sort of nap of the earth, no different than helicopter pilots do when they're flying low level, to be able to sort of understand that topography, but then also when you go to your next trajectory, that the system doesn't hit the towers. And I think that's one of the really frustrating things that we've seen with other systems in the past. It makes it a lot more straightforward from that perspective. So I do think it's really beneficial to have the navigation really tied into the specific implants, because it understands what's there. And I think that's one of the really differentiating things from the system.
Agreed. Yeah.
One comment on that, Ron, too, is, PERT cases or trauma cases, it makes a very easy and beneficial, and makes a lot of sense. But if you look at where we've headed in deformity surgery, so the multi-rod constructs and the number of rods people are placing really from the thoracolumbar junction down to the sacrum. So, some people are advocating 3, 4, even 6 rods and really sifting that construct in. When you do that on the fly, sometimes it's hard to kind of map out how everything's going to line up, right? And it's very beneficial to understand how to bend your rod in a sagittal plane and not have to deviate in the coronal plane. So when we start to plan multi-rod constructs using a platform like this, you do all the thought process and the work up front. And then in the surgery, right, we know these are long surgeries. We really get to reduce OR time and time with the patient under anesthesia. And so those constructs come together beautifully using this preoperative planning software.
Yeah, I think another thing, Jeff, that you sort of pointed out, and I sort of tried to highlight a little bit, is that, obviously there's many things, that we're all looking forward to doing, as automation improves. And, I often give a talk and I show, industrial assembly line in the automobile manufacturing from 40, 50 years ago, where it was much more amazing than it was when they sort of made the Model T and the Model A Fords, where, it was a human putting everything together. And certainly anyone who's ever owned or worked on an old car, oftentimes you'll see a screw that's somewhere lost in the door. And every time, you go to drive, you hear this thing rattling, you can't figure it out. And compared to now, where companies, are using complete automation, where 96% of the car, is done by a robot. And so as a result, it's essentially perfect. It's reproducible. It's the same thing. And as you mentioned, there's other things that we're going to be doing, hopefully in the future, that will continue to do this. But talk a little bit about, some of the intangibles. And so, we talk about, and you mentioned a lot about the economics, and we think about capital equipment, we think about, other things, and, saving money with processing. But what about the intangibles for a physician and for a surgeon? We all do these cases, and I often comment that no matter how straightforward the case is, even sometimes a discectomy, you always have 20 or 40 seconds of cold sweat. But what do you think about, systems like this that make things reproducible for you, and what's the maybe cognitive benefit or even emotional benefit on you as you do some of these surgeries with reproducible systems?
Yeah, so you guys both hit it on the head when you talked about stress reduction. I mean, I look at when I walk in the hospital in the morning to when I leave, I have a certain amount of, currency of stress that I want to spend. And if I spend too much, my wife knows when I get home, and my kids notice it when I get home. And so throughout that day, I'd love to save as much of that as I can, and that emotional energy. The difficult part about that is we talk about it, right? When people that use the system can talk about it back and forth, and that's hard to put a finger on. That's hard to put in print, right? So how do you measure that, right? So I thought of measuring cortisol levels in surgeons as they do it versus not, using systems, looking at urine output, glucose levels, things like that. There's really not an objective way to measure that. But if you talk to people that have bought into this type of technology and that use it on a day-to-day basis, everybody says that across the board, right? So they say that, my energy expenditure for fixation now gets to be spent elsewhere. And, like I said, I harp on understanding the failure points, understanding where it's going to burn you. And so it's not like it's blind and don't pay attention. It's still your surgery and your patient that you need to take care of, but you get to spend your energy elsewhere, right? And that is very valuable in this type of technology. It's just really hard to put your finger on and objectify it.
Yeah, maybe Avery, on that same vein, maybe you can comment, that case that you showed that had a prior, thoracic fusion, had significant distal junctional failure that you end up revising down to the pelvis. Just talk us a little bit about that, who's someone within their first sort of 5 years of practice. That's obviously a very hard case. That's a case that, most surgeons, should want to refer to a center that does that quite a bit. And even though you comment on it, but I think it's important to highlight, how that changes how you look at that case, especially with, robust fusion mass. You could see it there in the CT scan, with not just planning it, but also executing that type of case.
Yeah, and that's the case that I think really highlights the benefit of the Mazor system, robotic technology in general, is having the assistants in the OR to do that. I mean, just like Jeff talked about, like you've talked about, stress reduction in the OR is a big part of why we use this system. And it is true. I mean, it's you notice when you leave a case and you've been slogging away doing freehand screws or struggling with pedicles. It's different than when you have robotic assistance. And so that sort of case, when you go in, you have a plan that you've already walked through on the software. You have a plan that you've already talked with your team about, and you go in and you've gone through this, you set it up, and the Mazor helps you just execute that plan. I think you still have to be cognizant of what's going on. There's checks and balances. You have to make sure you agree with what the robotic technology is telling you. You have to be aware of what's going on, but having that ability to identify anatomy, help place pedicle screws is huge, and it really does elevate your ability a little bit. I think. I mean, it's not going to make you a great surgeon, but I think it will help you become a better surgeon and a more confident surgeon at times. And for me, that's been a big part of it. It's really helped in that way.
Yeah, and I think even when we look at these cases, and my very first TLIF, MIS TLIF with the robot, this was the Renaissance system. I did the technique in the procedure the way I normally did it was make 2 Wiltse incisions, place my inner body, and then place my screws. And with the first system, I realized that I didn't have the trajectory the same, and I ended up with 4 incisions, side by side by side by side. And that was the first case that really clued me in to say, maybe I'm not doing this surgery as efficiently and as well as I should be doing it. Because prior to that, using Jamshedes and fluoro, we worry about, the radiation. It's a lot of radiation. I was on a call earlier today with a private practice group in Minnesota. And one of the things, they were talking about is we use a lot of fluoro. And, we're timing out the machine and, all these types of things. And I think that's one of the things that's made it beneficial. But really extrapolating on that, it's completely changed how I do surgery. And like nothing else, even when you're used to doing freehand and you think you're pretty facile and you have your workflow and you're continuing to improve on that and you get 10, 12 years into practice like I was, and all of a sudden you completely do a 180 and say, you know what, I'm going to do it differently. I can tell you with these smaller surgeries, especially things like pars repairs and trauma cases and MIS TLIFs and prior fusion masses and S2AI screws, I do it better today than I did 5 years ago. And I'm fully willing to admit at this point that when the system, if I don't have it planned for the system, or if there's some issue with the system, it makes me a little bit upset because I think I can do it better with it at this point because once again, it does reduce the stress, but we also know that when the system works, it's incredibly efficient comparatively, and I do surgery better. And I think that's ultimately is what's going to help our patients, moving forward.
That's good to hear. And I would ask you and Jeff both is, how long do you think it took for you to get over that learning curve, the initial learning curve? And then how long did it take you to feel like, hey, I am better with this technology than I am without it?
Yeah, that's a great question. So, I pulled all my data to try to write up what our learning curve looked like. And it was pretty surprising that we couldn't define a learning curve. And then I thought to myself, mentally, how many cases was it before I really felt that I started to get comfortable with the technology and my team got comfortable with it? And I felt it was between 7 and 10 cases. And so there's a caveat to that though. So one, I knew I was going to be all in on this type of technology, and that's that offsets that learning curve quite a bit because my team in the OR, we spent time the evening before going through a dry run. We talked about it several times. We talked about the setup. We went through even the second, third, fourth cases, we went through dry runs. So we spent a lot of energy up front. And if you don't get that buy-in or have that buy-in, that learning curve is going to be a little bit longer. If you look at the literature, it's anywhere from, people talking about no learning curve to up to 30 or 40 cases. And so I think I was on the shorter end of that learning curve, but between 7 and 10 cases. Also, I spent a couple extra days in the lab prior to us obtaining the robot. Like I said, I spent 18 months kicking and screaming trying to get one into our system. So in that 18 months, I was spending time in the lab. So I'm not saying that it only takes 7 cases for everybody in the world to get comfortable with it, but it's shorter than you think. But on the flip side of that, you need to have realistic expectations. If you think you're going to walk in case 1, it's going to be beautiful, no hiccups. They're going to be frustrated. It's going to be sitting in the hall. So have realistic expectations. The learning curve is there, but in my hands, it's not too long.
Yeah, I think I would echo that too. We just submitted a few weeks ago 108 consecutive 1 and 2 level fusions with robotic assistance. And we did see a little bit of an improvement in terms of time for the surgeries, sort of every, 12 or 14 cases, during this difference, but it wasn't significantly different than what I would have thought. And I think like most things, once again, this system is very rigid. And so from our standpoint, it's almost sort of takes a lot of the thought process out. The end effector goes where it's supposed to go. The subtleties, I think, are things, like Jeff brought up before, skive and shift and soft tissue retraction. But I think the huge benefit is that we have enough surgeons now throughout the US and, really world, but certainly throughout the US, that I think for, surgeons who are considering adopting this technology or recently got a system, we have a lot of things in place where those surgeons can go visit centers who have done a couple hundred cases, and you can really take that learning curve and make it now, a dozen cases as opposed to 100 cases, because someone else has had it figured out. Someone else has made the mistake. Someone else has had, the pitfalls and tribulations that go with any new technology or any new surgical procedure. And so if you're going to use a tube, we used to go to, Tennessee and, visit a surgeon who had done, 800 tubular surgeries. And when you do that, you sort of see some of the nuances. Obviously, you go back, you do cases yourself, and then you can set up, additional, WebExes or virtual visits or reverse VSPs to help sort of get the learning curve up. But I think that's the huge benefit, is that you really, and the same thing I did, when I first started with the Renaissance system, is I visited a surgeon who I knew was trained well and had been using the system for about 100 cases. And it really made it good. And it's nice to see some of the, workarounds. And I think that's one thing that we have the ability now to do, is that enough people have a good experience that they can really sort of help new surgeons and adopters of this technology really get over that learning curve very, very quickly compared to, 10 years ago, certainly.
Yeah, that's great.
So I think at this time, we'll go ahead and wrap things up. And I want to thank Avery Buchholz and Jeff Gum from University of Virginia and Leatherman in Kentucky, respectively, for really talking about all their learning experiences, how this technology has changed the way they do surgery. And certainly, I think as we get better at most things and improve workflows, it's all ultimately going to be better for our patients. Thank you.
Thanks, Ron. Thanks, Avery.
Thanks, Jeff.